Welcome to the conference session titled Transplant for Aplastic Anemia and PNH. Thank you for joining us. My name is Akirka Ashadu, and I'm the Program Content Manager at AMDSIF, and I'll be moderating the presentation today. As we get started, we want to recognize the generosity of our corporate sponsors and the generous support of our patients, families, and caregivers with our conference today. Immediately following the presentation, there will be a question and answer session. If you are participating online, please feel free to submit questions at any time during the presentation from the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box, and when you have finished typing your question, hit enter, and we'll do our best to get all questions. When asking questions, I respectfully ask that you do two things to help me manage the incoming questions. First, that you submit your entire question at the same time, and second, that you do not share private health information in your question. Our speakers do not answer any specific questions related to your health care. Today's specialist is Michael Pulsipher. Dr. Pulsipher is currently the Division Chief of Pediatric Hematology at the Intermountain Primary Children's Hospital and Oncology, Director of the Children's and Adolescent Cancer Initiative at the Huntsman Cancer Institute, and a Presidential Chair in Pediatric Oncology and Hematology at the University of Utah. His research interests include allogeneic transplantation and cell therapy for acute leukemias, especially where he is running ALL, where he is running national research trials aimed at testing haploidentical approaches and assessing the role of NGS MRD in identifying patients' ability to undergo less intensive BMT approaches. Dr. Pulsipher's work in cell therapy helped lead to the FDA approval of the first CAR T cell treatment, and he continues to run trials in CAR T, NK, and virus-specific T cell therapies. Dr. Pulsipher has also done extensive work in reduced toxicity approaches to transplantation of both malignant and non-malignant disorders, and has run national protocols for patients with immunodeficiencies, HLH, and bone marrow failure. Finally, he has run several large trials assessing the safety and quality of life of pediatric bone marrow donors, and is currently running a large national trial looking at the psychological well-being of donor and recipient families as they go through the transplant process. With that said, welcome Dr. Pulsipher.
Thank you very much. I look forward to doing this. As I mentioned a little bit earlier, I love treating patients with aplastic anemia, and I want to share with you my excitement about some important changes that are occurring in the therapies associated with aplastic anemia. So these are my disclosures, nothing really particularly relevant to this particular talk. So what I hope to do is quickly, all of you kind of know what aplastic anemia is, but it's important to rule out other causes. We've actually discussed that in some of the earlier talks, and so I won't spend a lot of time. But what I then will focus on is initial therapy. What are the implications of doing transplant versus non-transplant therapies? And then talk about the fact that newer approaches to unrelated donor transplantation and haploidentical transplantation are leading to high rates of success. Now, success is one thing. We have to understand, though, that sometimes success at a transplant will come at a price. And we need to talk a little bit about that. And when I'm finished, what I hope to do is give some insight into what perhaps may, over the next few years, become the best first therapy, as opposed to the way we're doing it right now. So, again, this is a picture you've seen before many times. This is what a healthy marrow looks like, with lots of cells and occasional fat globules, as opposed to an aplastic marrow where all you see is lots of fat and very few cells, and that's aplastic anemia. So when that occurs, of course, I apologize, this isn't advancing. Let's see. There we go. That went backwards. I know forwards. Yeah, I did. I was using it. It wasn't working. This works though. Okay. Very good. I apologize for that. So, as patients are diagnosed with aplastic anemia, the important thing to understand is we have to be sure of that diagnosis. And the reason why is if they come to a point of transplantation, our transplant approaches are entirely different with aplastic anemia compared to myelodysplastic syndrome or an inherited bone marrow failure syndromes. Just an example, myelodysplastic syndromes are cellular marrows that contain lots of elements that take much more intensive therapies in order to clear those marrows of those particular cells prior to being able to do a bone marrow transplant. Whereas aplastic anemia marrows generally are relatively empty, and a relatively empty marrow is easier to get a graft in using a reduced toxicity approach. So bottom line is really important to kind of sort through this. And there are specific tests that are done for MDS. What we always need to do, of course, is to look at it very carefully and do cytogenetic and FISH testing. A big distinguishing characteristic of MDS is that there are genetic abnormalities that are clear that are oftentimes associated with MDS, and we can see that. In addition, the bone marrows look different, the cells are growing abnormally. For hereditary bone marrow failure syndromes, I'll mention them briefly in a minute. This definition at the bottom is the standard definition of severe aplastic anemia, where you have 2 cell lines down, and you have 2 of 3 criteria. Your ANC is less than 500, or your platelets are less than 20,000, requiring transfusions in many cases, or your retic count is less than 1% and you need blood transfusion. You also generally have very low cellularity, and there's another category of very severe aplastic anemia where your ANC is a little bit lower than that, at about 200. So there's a whole series of hereditary marrow failure syndromes. Those of you who saw Sunit's talk this morning really got to learn a lot about them. The most important thing to understand is that if we need to do transplantation of these, we have to understand what the particular disorder is. Especially for the one that's on the top of the list, which is Fanconi anemia, where you need to be incredibly careful. Fanconi anemia patients are very, very sensitive to chemotherapy and other types of treatments we use for transplant. So if you're going to transplant a Fanconi anemia patient, you need to know about it so you don't harm them. But many of these other inherited marrow failure syndromes also have special sensitivities associated with their transplant that we need to be aware of. Now, what makes it so that you might need further evaluation? These are things that you know, it's never too late to keep looking for a potential inherited marrow failure syndrome, because even though we think we have aplastic anemia, sometimes later on we figure out that there was an inherited marrow failure syndrome. And what I have here is a list of a whole bunch of physical findings. Many of you may have heard about these things. You can have odd things associated with your thumb or your arm. You can have spots on your skin, large brown spots called cafe au lait spots. You can have different shaped ears. You can have skin changes such as leukoplakia. You can have different things going on with school. You can have neurologic findings, etc. So bottom line is, most patients with regular aplastic anemia patients are just healthy children who look normal. And when you see abnormalities, then you need to be careful. And you need to look really into that and sort it out. It's not only the physical findings, but it's also testing. If you see abnormalities with heart, kidney, liver, that could add up to different types of disorders. So we have to really keep that in mind. Now, one interesting study, just to point out about what we're learning, when we look very carefully, we tend to find disorders, even in patients we're not 100% sure about. Now, this is a very interesting study that was published in Blood a couple of years ago. It was done by a French group, and what they did is they said, these aren't the classic disorders that we know about very well with aplastic anemia. These are patients where we're just worried about it. They don't quite look right. They may be shorter than they should be, or they maybe have something about their physical appearance that's not classic, but it's just abnormal. And what they did is they took those patients and sequenced them all very intensely to see if they could find something. And the interesting thing about that was that they found abnormalities in half of those patients, 48% of them. And this is a mixture of a whole series of abnormalities that we found. And those of you who have kind of watched this field, these are things associated with dyskeratosis congenita. These are things associated with myelodysplastic syndromes. These are inherited diseases associated with low platelets. These are associated with neutrophil disorders. In other words, bottom line is, if something's not quite right, it's always good to get sequencing and make absolutely sure that you know what you're treating. Okay, so now that I've done that little introduction, let's assume you're a patient, your loved one or you have good old idiopathic aplastic anemia. And let's talk a little bit about treatment. So I want to point out here that these are treatments that include all of the patients reported to the Center for International Blood and Marrow Transplant Research. So that's mostly North American centers, so mostly the US, but there are some other centers outside of the US that contribute to this as well. And what you notice here is the outcomes when you add them all together and you look at it over the last 10 years. Now, these aren't patients who are on study. Sometimes studies look better than this because one thing you should all understand when you look at papers about aplastic anemia, the patients who went on the trial had to be eligible for the trial. So sometimes the patients who were too sick to go on the trial never made it. But this is kind of everybody because we have to report all of our transplants to the CIBMTR. And what you see here is a great outcome if you have a matched sibling donor, where survival is 95%. And I always love doing matched sibling transplants for aplastic anemia because they do great in general. And because of that, it's really become our standard of care for young patients. They all tend to get a matched sibling transplant when they go. Now, below that, you see matched unrelated donor. Now, this is survival. This means that about 10% of them have some sort of complication or problem, and they end up not surviving after the transplant. Haplo, it looks like they're getting better, but a little bit less than that. This is about, on average, about 85%, as you can see. Now, again, you may see better in individual studies, but still, as we get more mismatches associated with the transplant, the likelihood of success goes down a little bit. And when you get down to what we call mismatched unrelated donor, this goes down into about the 70% range. So it's important to understand that these differences exist. Now, you'll see individual studies where, in fact, there was a really promising mismatch study where all of a sudden that survival was much better, greater than 90%. But that was with a very specialized procedure. There are better approaches to haploidentical transplantation. We may be getting better. Now, when you get above 18 years, you got to be a little more careful. Clearly, matched sibling is still the best with survival just below 90%, but it gets a little bit worse over time. And you can see that MUD and haplo are about the same at about 80%, and mismatched donors as low as 60%. Now, why are the age greater than 18 years so much worse? It's mainly because these are not patients that are 19 and 20. These are patients that on average are probably 60, because there are two major peaks for aplastic anemia. Your first peak is in the first, it peaks about in the second decade of life, and then you have another peak of aplastic anemia that is in patients that are in their 50s and 60s and 70s. So bottom line is, they're really different populations. In general, most of the patients in this category are much older. Now, this has led us to have the following approach, and this is often debated. So this is an article that Phil Scheinberg published in 2012, and it hasn't changed much, but some people are trying to change it. Essentially, you get your initial diagnosis of aplastic anemia, and he proposed if you're greater than 40, and then you should go directly to immune suppressive therapy, no matter whether you have a matched sibling or not. But if you're less than 40, he proposed matched sibling transplantation. And that's mainly because of the risk of chronic GVHD in an older patient Many people feel because the chronic graft versus host disease can occur more often, it's probably a good idea to start with immune suppression therapy, see if that works, and then avoid that. Now, some centers are saying we can do better even in older patients with matched siblings, and maybe they want to do that. Some centers are now pushing other types of transplants into patients who are older than 40. And I'll mention some of those studies. But bottom line, you get your initial therapy. The standard of care therapy in the United States where we have horse ATG is horse ATG plus cyclosporin, and eltrombopag in adults and no eltrombopag in children, and I'll talk just a little bit about that. And they look for response. Now, Phil says 6 months. Now, the way responses go is approximately 80% of responses, if they're going to occur, will occur within the first 3 months, especially with eltrombopag, where it's moved all the responses up probably at least 4 weeks earlier than they were occurring otherwise. When you get to 4 months, it's only a little bit more. Maybe you're up to, if you're going to respond, 90% have responded. A few more might respond if you get to a year, but it's difficult to go that long, especially if you're severely neutropenic. So that's really important to keep in mind with immune suppression. Some people tend to try to transplant between 3 to 4 months after their initial treatment, or at least get a transplant ready. Other people are purists and like to wait a little bit longer. But I tend to say, okay, if you're at 3 months and you haven't responded, let's start getting a transplant ready to go. And if the patient is healthy and ready to go, then we can move forward with transplant. Now, this goes on to talk about different types of donors. And this occurred mainly at a time where unrelated donors, fully matched unrelated donors were really kind of the main thing that people did. But we have more to offer, and I'll talk to you a little bit more about that. One thing that's important to understand, though, is the field has begun to change. And that is many things have been published about pediatric patients having really good response rates. And there's a big movement in pediatrics to try to do transplant up front. So let's talk a tiny bit about a pediatric study of immune suppressive therapy. And I really mainly am putting this in to kind of contrast it with adult. This is response criteria. And one thing you should understand, when you start with little or no counts, sorry about this, when you start with very low counts, a response may look just a tiny bit better than where you started. But it's still better than where you started, so we call it a response. So even though your hemoglobin may be just barely above 8 and you still may be tired all the time, even though your platelet count may be only 25,000 and you're still susceptible to bleeding and bad bruising and you can't play sports, but you're not requiring transfusions all the time, we're calling that response. And of course, the most important of all the responses is getting your ANC greater than 500, because infection is generally the biggest risk that you run into. So PR means you're responding in these areas, you become transfusion independent, and your ANC is above 500. If you have a very good partial response, then that means your platelets are higher, and a complete response by this criteria, your hemoglobin is above 10, which means you've got decent energy, your ANC is above 1,000, meaning you're very unlikely to get a severe infection, and your platelets are above 100,000, meaning you can do pretty vigorous activity. So what we really want in immune suppression therapy is a complete response if we can get it. Now this is, again, a pediatric study. All of the centers in North America who put in data. And what you can see here is good news. 5 years later, right here, 93% of patients are still alive. They're doing okay. But many have not responded. This is the initial non-response, okay? You can see that's happening during that first year where patients go on to get other therapies. And then slowly, patients will tend to have a fall off in response. The good news here is about half of them are cured and put into a really good remission. Now, I haven't proven this yet, but we're working on it. In general, we have some preliminary data that suggests if you have a complete response at 2 years and you're off immune suppression after immune suppressive therapy, then your likelihood of survival without relapse is very, very high. So one of the studies I'm working on will hopefully confirm that a little bit later. But in general, when you get treated with immune suppression therapy, there is some fall off over time. But about half of the patients will be done and won't necessarily need more therapy. Now, this is a curve, again in children, where you started and you had a response. And the question here is, all right, if you had an initial response, how long does that last? Now, ignore these because there wasn't enough follow-up to say that those lines it's really going to go down that much. When you see big drop-offs at the end of a curve like this, that generally just means you don't have enough patients out that far. But basically, what this means is once you have a good response, you're going to fail that response about 20 to 30% of the time, okay? So you're going to have a good response initially, and that means if you're lucky enough to have that good response, many times you are cured just with that alone. But coming back to this, you see the excellent response that children have to matched siblings really means that that's going to be considered our standard of care, and we're going to plan for matched sibling transplant. Now, before we go to talk about unrelated donor and haploidentical transplant, I want to talk a little bit about chronic graft-versus-host disease. So it's super important to understand that matched sibling transplant for aplastic anemia usually has very low rates of chronic graft-versus-host disease. So I think in my career I've transplanted about 50 kids with matched siblings, 100% survival, one case of severe chronic GVHD. It doesn't happen very often. The publications that you see have shown chronic graft-versus-host disease rates in the 5 to 9% range. So bottom line, it's rare. We use really good ways of preventing graft-versus-host disease, so it doesn't happen very often. But unrelated transplantation is very different. The reason for that is because mismatch and HLA mismatch can lead to chronic GVHD, even in children, at higher rates. So bottom line, if you do unrelated donor transplantation, you can get as high as a 20% rate of chronic graft-versus-host disease. Now, when chronic graft-versus-host disease occurs, usually about half of it is not too bad. It is someone who has some skin changes and they need to maybe use cream on it. They're not necessarily on systemic therapy, and they're doing reasonably well and having a pretty good and functional life. But about half of the patients with chronic GVHD have all sorts of stuff going on. They may require multiple medications. They may be admitted to the hospital several times in a given year because every time they get a fever, they have to go into the hospital. They may end up having their life disrupted because they have to take extra precautions not to get infections. So anytime you see a rate of chronic GVHD, just kind of keep it in your mind that half of it is probably mild and half of it may be severe enough that it's really affecting your life. Now, the second thing to say about chronic GVHD as we begin to talk about unrelated donor and haplotransplants is that haplotransplantation and even unrelated donor transplantation, when using a new approach to transplantation called post-transplant cyclophosphamide, the rates of chronic graft-versus-host disease are much lower. In many cases, they're less than 10%. And while it's terrible to get it, that's a low enough rate that you can feel more comfortable going into the procedure because the vast majority of people are not getting that type of complication. Okay, so let me tell you about one study that I did with Amy DeZern through the Bone Marrow Transplant Clinical Trials Network, and we published this last year in Lancet Hematology. And our hypothesis was straightforward. We had done a previous trial in bone marrow transplantation and had shown the ideal doses of a medicine called cyclophosphamide to get the best outcomes with unrelated donors. And so we really worked hard working with this group, the BMT Clinical Trials Network, and our goal was now to say, okay, we know how to transplant someone if they have a match, but what if you don't have a match? And so many people don't. If you look at the general population, if you are a Caucasian Northern European, you have maybe a 70% chance of having a complete match, a 10 of 10. But if you are black, you have about a 20% chance. If you are Hispanic, maybe very similar, actually 20 to 25% chance. So bottom line is most minorities have less than a 50% chance of having a good match. So we really needed to find a way to do a high-quality transplant in patients who just didn't have a match. So we put together a group, and we very carefully tried to study cord blood and haplo. It turned out at the time that the haplo transplants were getting better so much faster that no one wanted to do cord blood. By the time we opened the study, everyone said, we're not going to do cord blood. And so we just really focused on haploidentical transplantation. This was the preparative regimen we used. And let me just point it out so that you understand it. 2 doses of cyclophosphamide, but very low dose, at 12.5 milligrams per meter squared, and 2 doses of cyclophosphamide after the transplant at 50 milligrams per kilo. This is per kilo, sorry. This is not enough to affect your fertility. A single dose of low-dose radiation at 200 centigrade. This also is not enough to affect your fertility. Maybe. If you put it all together and you have chronic GVHD, the fertility may be affected. But by itself, we have several cases of individuals who went through this and were still able to conceive or bear children. So that's important to keep in mind. This is what's called a reduced toxicity or a reduced intensity treatment regimen. Now, one thing to point out about our patient population, and we enrolled 31 patients on this trial over a few years, and it took a while because most of the patients were getting transplanted with fully matched unrelated donors. These were just the ones that didn't have matches that ended up going on our trial. And what you see here is that there was a good blend between both pediatric and adult patients, kind of not quite half and half, but a good blend of both. And a really important thing here, that there was a large number of minorities involved in the trial. In fact, greater than 40% of the patients were minorities, whereas only about 20% of the patients across the country who were getting a transplant are minorities. So we were enriched. This involved a lot of patients who just couldn't find donors. And so we were able to get grafts in and have long-term survival in over 80% of these patients. Now, one thing that was interesting, we learned something, and if we just didn't count our first 5 patients, our survival was 90%. What we learned in this particular approach was you had to have a really good cellular bone marrow. And one crazy thing that's happened to some of our transplanters over the years, this starts with bone marrow, which we think is the best stem cell source for transplant in aplastic anemia most of the time. And most of the adult transplant centers were used to using peripheral blood stem cells. So when they get to the OR and you have to do this bone marrow harvest, it's very difficult. We weren't getting rich and high quality bone marrows. And so we made a requirement that they had to have at least a certain number of cells. And we trained all of our centers to do better bone marrow harvests. And then all of a sudden our outcomes got a lot better. So bottom line is, I think that this is better than just 80%. It's probably closer to 90% outcome if you have a really rich and cellular bone marrow using this haploidentical approach. Now, this was only patients who had failed transplant. And what you can see here is the acute GVHD cases occurred about 20% of the time. Now you see here about a 25% rate of chronic GVHD. Now the interesting thing about the chronic GVHD that we had with post-transplant cyclophosphamide is that 100% of our patients with chronic GVHD got off their GVHD therapy by 18 months after their transplant. So all of this GVHD was pretty mild. It was GVHD that could be taken care of. So again, I think that post-transplant cyclophosphamide is something that is really important in minimizing our severe chronic graft-versus-host disease. All right, and this shows when the counts came in. You see that they came in somewhere between day 15 to day 30. This is, let's see. So this is our neutrophils coming in, and this is our platelets coming in. with engraftment. So one thing that then happened after this trial is Dr. Dezern, Amy Dezern, who I worked with on this first study, went on to study a series of patients at her own center, which is Johns Hopkins University. And they said, well, what if we did this up front when you were first diagnosed? And they found that if they used the exact same protocol that I showed you, they had a bunch of rejections, 3 out of 7. And that really disturbed them. So they halted their protocol, and they thought very carefully, okay, how can we fix this? Why are we having so many rejections when we didn't have those rejections when patients had failed immune suppression therapy? Well, think of it this way. When you first present with aplastic anemia, there's probably a good chance that your T cells that are wiping out your bone marrow are highly active. And those T cells probably are not going to get eliminated with a mild transplant preparative regimen. And therefore, your chance of rejection is going to go up. And so essentially what they needed to do was increase the intensity of the preparative regimen. So rather than doing 1 dose of radiation, 200 centigrade, we increased it to 2 doses of radiation, 400 centigrade, and all of a sudden it made a big difference. And the next 20 patients all engrafted, and they all are alive. So this looks promising. Now, we don't have final rates of chronic graft-versus-host disease in these patients, and it's only 1 center. One thing I always like to warn patients about is you got to be careful trusting a single center study, because maybe that center only transplanted the good patients. We all, when we do studies or when we treat patients, we'll select patients that we think are going to benefit. And if someone we think is not going to benefit, we would not necessarily select them. So the only way to really know how your patient is going to do is having a multi-center study and having clear criteria for who is able to go on the study, and then your patient or you fit into that criteria. And then you can be more confident of the outcomes. So this trial is now going to be open through the Bone Marrow Transplant Clinical Trials Network to older patients across the country to see if we can replicate that survival. Now, let's talk a little bit about unrelated donor outcomes and why we're trying to figure out whether we can start with unrelated donor bone marrow transplantation in children. This is 2 studies. This is the BMT-CTN 0301 trial, and unfortunately this is only 12 months. So it doesn't give you the whole story. Some of these patients failed during year 1 to 2, but bottom line is they did really well in the first year and had good survival. This is a study that was a pediatric-only trial done by a British group, and they showed, again, very good survival. The trouble with this study is it was done over about 10 years, and they varied their protocols a little bit through the years. But bottom line is this looks really promising. When you're having survival greater than 90% consistently with upfront treatment of patients who have aplastic anemia, it looks like maybe it's something we should consider doing for all of our patients. Well, we were interested in trying to see whether we could even do this. Any of you who have been associated with an aplastic anemia diagnosis, what you notice is they're not well when they show up, right? They're very anemic, they're often infected, they need transfusions, they need to be cured of their infections. Sometimes they have organ damage because of their infections. It's very complicated. So the question is, can you take patients up front and get them to transplant quickly? And are parents willing to be randomized between an immune suppressive therapy approach and versus an unrelated donor approach? We wanted to find that out, whether we could do this. The reason why is when we decide what the very best upfront approaches are for transplant, we really want to be fair-minded, and we don't want to select patients by saying, oh, this is a really good healthy one, let's take that one to transplant, and this one that's sick, let's treat that one with immune suppressive therapy. We didn't want to do that. We don't want to bias ourselves as we're trying to sort this out. We think that the very best way to find out what the best therapy is up front for patients with aplastic anemia is to do a true randomized trial. Take every single patient that comes and randomize them either to get a transplant or to get immune suppression. Now, understand that no matter what you get, whether you get immune suppression or you get transplant, there's a good chance you're going to need a second therapy. So transplant leads to rejection between 5 to 15% of the time, so that means that up to 1 in 7 patients is going to reject their transplant. And transplant may sometimes lead to patients who have severe chronic GVHD, so you may need other therapies to get that taken care of. Immune suppression, some patients won't respond to that and will go to transplant within 3 to 6 months. Other patients will fail later and then get a second therapy. So bottom line is, there are several courses of treatment. There's immune suppression alone. There's immune suppression followed by 1 transplant. There's immune suppression followed by 2 transplants. There's transplant alone. There's transplant followed by rejection, followed by a second transplant. And what we want to know as we treat these patients is, if you take all of our newly diagnosed patients, you try to find donors for them, and you embark them on one course or another, what's the best for them? What's going to lead to the best outcomes early on? What's going to lead to the best outcomes later? And so you'll hear me talk a little bit about the trial that we're doing, and that's going to really give us this information so that we can really inform people as they make their decisions. So what we did with this is we opened this at 15 different centers and we enrolled 41 patients. And our hypothesis was that we could get at least 60% of them to transplant up front, because getting someone to transplant is hard, and we were worried that we wouldn't be able to get that many. Now, in reality, we got 85% of them to transplant as their first therapy, so we did really well with that. We figured out a way to use what we call a special screening procedure with the National Donor Program to get a donor really quickly. We then followed a lot of other things, including rates of graft versus host disease. Now, here's an interesting thing. Here's what happened with patients when we approached them. What we found was that we had 67 of our patients that consented to be screened for the trial. Of those, 57 of them actually had aplastic anemia. So there were a bunch of patients who we screened, but eventually they had MDS, or they had ALL, or they had something different. So 50% of them had aplastic anemia. Of those, 40% of them agreed to go on the trial and were randomized. So let's take this through, and this is reality. I always wish, as someone who's really trying to figure out the best therapies, that everyone would be willing to go on the trial. But that's just not reality. And let me just tell you why patients didn't go on it. So here, one of our most common things was people just didn't like the idea of being randomized. For some reason, people have the notion that doctors know the right answer, and therefore they should tell them what their child should be treated versus these 2 therapies. I can honestly tell you, I don't know what the best therapy is. But some people just hate being randomized, and they wanted to pick one therapy or the other. And of those, half of them didn't want BMT and half of them didn't want immune suppression therapy. So it was kind of split even between the patients who really definitively didn't want one. We had one patient who was judged to be too sick. And we had a couple patients where their telomeres were low and the doctors felt uncomfortable randomizing them. The most common thing, of course, was that 20% of them had a sibling donor. And that happy ending there, they just went to transplant with their sibling donor. And then only about 12% of them, we didn't have an unrelated donor available. And we were surprised about that. I thought it was going to be higher, but we were able to find at least a single antigen mismatch in all the rest of them. So it's interesting why people who were willing to go on and people who were not. Now here's what our cohort looked like at the very end. And as you can see here, We're enriched. We've got about 35% of our patients who are minorities, up to 40% in some cases. Could we get patients started on time? Immune suppression, of course, got started very quickly, less than a week. We had only 17 of the 20 patients get their transplant first. The other patients couldn't. The reason why is a donor fell through with with two patients, and one patient got to the point of transplant and they weren't transplant eligible because their liver function tests were too high. So basically that's what we ended up with our initial treatment. Now, how did they do? For immune suppression therapy, what ended up happening is that 65% had an initial response, and what we've seen is response rates in the 70 to 80%, so it's within normal limits because it's a small study. We had 3 patients who failed and were salvaged with transplant. We had 7 patients who failed their initial immune suppression therapy, and then they got transplanted, and 1 needed to be transplanted twice. So as you can see here, as I mentioned, sometimes you need immune suppression therapy and 2 transplants in order to get you healed. Now, as treated, 10 out of 23 who were initially treated did well and were cured with their immune suppression therapy alone. So that's about half were cured with immune suppression therapy alone. So in the BMT arm, and this is important to understand too, 3 of them couldn't get to BMT first. The donors fell through, and like I said, they weren't eligible. 2 had an acute rejection, 2 developed post-transplant cases of severe pancytopenia, and then 13 did great and had no other problems. So one of the things that I want to emphasize with this is no matter what road you go down, you might need a second therapy. So that's an important thing to keep in mind. So bottom line is that 13 out of 17 were in continued response with their last follow-up. And this is what those 2 things look like. Now, it looks like the transplant arm might be better than the non-transplant arm for at least your initial therapy. But still, there's a lot of people on the non-transplant arm who are cured by their immune suppression, and this is not statistically significant. So this study was not designed for that. Instead, our next study is designed to take a look at this. Now, one thing we learned is that the same thing that I showed you before. You remember how I mentioned to you that in the haplo setting, when you start treating patients up front, they probably need more intensity. We think that's probably the case in the unrelated donor setting as well. So in order to approach that, we have actually increased. We started with only 1 dose of cyclophosphamide at 50 milligrams per kilogram, and we believe they need 2 doses. So in the phase 3 trial that we're running right now, we're doing a slightly higher dose of cyclophosphamide. Now, why do all of these doses of the transplant preparative regimen matter? Here's why. So if you look at the radiation dose, so what you see here is that a prepubertal female, if you give them even up to 10 gray, which is 5 of those doses I was talking to you about, they're probably going to be okay, and they might have good fertility. But a postpubertal, 1 dose may affect their ability to have children, and 2 doses is much more likely. With males, see here, 1 to 3 might give azoospermia where your sperm count's down. None of the transplant doses gave enough cyclophosphamide to affect fertility. So bottom line is we don't know in detail what's going to allow us to preserve fertility. But what we suspect is a single transplant with low dose radiation or no radiation has a very good chance of fertility. A single transplant with higher dose radiation has a big risk that you're going to lose fertility. If you have to have 2 transplants, it's very likely you're going to lose fertility, or at least have fertility impaired. We're going to study that really carefully in the phase 3 trial. So this is the new trial that we're running. And this is a great trial that is going to enroll 234 children across the country. We have it open already at 28 centers, and we're aiming for 50 centers. We're going to run this over the next 7 years. It's been running now for about a year. Our hypothesis is that for the initial treatment, we're going to have 20% less failure in the unrelated donor transplant arm. And so that's what we're looking at as our main thing. We're also looking at quality of life, which is very, very important. We want to know how patients are doing. Do they really feel good? Do they feel normal? How long does it take them to get back to normal? But most importantly, we're going to be studying other things that really matter in aplastic anemia. We're going to be looking at gonadal function, because we want to know, with all these combinations of treatments, what is going to really affect your gonadal function. Now, we can't measure fertility. In order to measure fertility, we'd have to study these patients for 30 years, because it takes that long for people to have children. But we can measure indirect markers of fertility. We can measure whether they have sperm production, or whether they have hormones that are capable of supporting normal spermatogenesis and the ability to have good ovarian function. So we're looking at that. And then finally, we're looking at one complication that occurs too often after aplastic anemia, and that is MDS, and moving on to have complications associated with AML. So we're looking at clonality, which is a predictor of that, and we're looking at this carefully in all of these different patients to know what patients' risks are with this. We're looking in detail at their genetics, because we want to make sure that everyone has true aplastic anemia. If we have a patient who has an inherited bone marrow failure syndrome, we're going to know that, because we're going to sequence all these patients. So this is a really long, detailed summary that I kind of went over it in great detail. Bottom line, sibling BMT is really our standard of care for younger patients. In older patients, there may be a high risk of chronic GVHD, so you need to think twice. Unrelated donor BMT survival has improved a lot, but you have to be aware of risks of chronic GVHD. Haplo survival has also improved, and we need to get better at it and make sure that we're doing it really well. Immune suppressive therapy is great in adults, adding eltrombopag. I didn't go into detail what happens in children with eltrombopag. They just haven't responded as well. It hasn't improved the response rates, and they've had actually earlier failures when they use eltrombopag. So we generally don't use it in children. So the question is, should we do unrelated donor or haplo-BMT up front? There's our phase 3 trial where we're studying it in children. There's the CTN trial coming that's going to be studying upfront unrelated donor and haplotransplant in adults. And in all these trials, we need to know and understand what our risk of fertility loss, rejection, and chronic graft-versus-host disease are, so that if we make a decision to go to BMT early, we're making it with our eyes open. So I think that's all I have, and many, many great people who I've worked with through the years. And I'm very happy to take questions.
Thank you, Dr. Pulsipher. So I think we have time for a couple of questions. So the first question that I wanted to ask was, if you are diagnosed with aplastic and had a transplant, do you need to be concerned about developing PNH?
No. Only if you reject. Almost always, if you have a decent amount of chimerism, and chimerism is a measure of how much from your transplant is actually from your donor, if you have reasonable levels of chimerism, the likelihood of going on to develop PNH is exceptionally low.
Thank you. And our second question is, can a transplant patient donate blood? I'm 7 years out of a transplant.
You should be able to, but I'm trying to remember. Charlie, tell me. Can organ transplant patients get it? I'm trying to remember. I'm thinking of the screening questions.
It's a good question. I'm not sure either.
Yeah. The screening questions change all the time, and I can't recall. I know that solid organ transplant donor recipients can't. So it wouldn't surprise me if they get screened out. But they can always try. See if they get screened out.
Thank you so much, Dr. Pulsipher, for sharing your time and expertise with us. If you would want to watch this session again at a later time, it will be available on the conference platform in the next hour by accessing the session and clicking on replay or by navigating the on-demand tab in the platform hub. If we were not able to answer your question today, you can send it to us at any time in 3 ways. Sending an email to help@aamds.org, calling the AAMDSIF helpline at 800-747-2820, or submitting a question on our Facebook page. If you are watching online, please take a few minutes to complete the session survey. Your input is important to us and helps us plan future educational programming. Also, be sure to visit the exhibit hall and chat with our conference sponsors. The next educational session will be available in approximately 15 minutes. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and for making us your research source of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to help you and your family as we have for the past 40 years. This concludes the session.